answer to the following questions. The hepatic glucose production. The insulin resistance is defined by the decreased ability of insulin to mediate these metabolic actions. And as a consequence, we may observe an hyperinsulinism and an impaired glucose tolerance. The problem is not about the insulin or the receptor. The problem is about about a post-binding defect. It is the consequence of the hyperphosphorylation of the receptor of insulin after binding with its receptor. This is a very hot topic. The first publication have been published in 1980. And since that day, we had a lot of publication, and we have reached in 2011 2,000 publication that have focused on the association between insulin resistance and PCOS. So the insulin sensitizers are supposed to regulate and to restore the insulin sensitivity. But you have all to know that the first insulin sensitizer is not a drug, it's the lifestyle intervention. Losing weight and having physical activity is the best way to restore the insulin sensitivity. But we have also some drugs like metformin, thiazolinidinidione, and D-chiroinositol. So the metformin is the most widely and extensively used insulin sensitizer in PCOS. It reduces the hepatic glucose output, but it also increases the insulin intake by muscles. It may also reduce the androgen synthesizers in the ovary. The TZD class has also been proposed to treat the insulin resistance, and we have the rosiglitazone and the pioglitazone. Troglitazone have been withdrawn from the market due to its toxicity, and these drugs have also several adverse effects, like increasing the risk of congestive heart failure and a bone fracture and also bladder cancer. So why we are speaking here in IVF Congress about insulin resistance? That's because the insulin resistance will have an impact on the ovulation and on pregnancy in PCOS patients. And insulin-resistant women with PCOS may experience a lower ovulation rate and are more likely to develop a resistance to clomiphene treatment. We also have to be aware that our patients are also at higher risk of developing type 2 diabetes, and the prevalence of metabolic syndrome is higher in PCOS patients. All of that may have as a consequence a higher mortality from cardiovascular disease. So the consensus of Thessaloniki have already answered to the questions. The experts have said no, the metformin treatment should be restricted to only the PCOS patients that have a glucose intolerance. But since that day, some new data have been published. So we are going to review all of this data. So if all the PCOS patients should be treated for insulin resistance, that means that first, all PCOS patients are insulin resistant, and that the metformin or the insulin sensitizers treatment will have more benefit than side effect and risk in all PCOS patients. The benefits may be cycle regularity and restoring fertility, for example, and also improving the hyperandrogenism and improving metabolic parameter. So I'm going to try to answer to these two questions. But first of all, you have to note that assessing the insulin resistance is hard, because the gold standard test is the hyperinsulinemic glycemic glucose clamp technique, which is very hard to be performed in routine clinical practice. So some other surrogate marker of insulin resistance have been proposed, but no one of them is as accurate as the gold standard test. So are all PCOS patients presenting insulin resistance? No, clearly. 40 to 70% of patients will present insulin resistance. And this variability is probably due to a variability in PCOS definition and also to the population that have been included in this study and the ethnics, and also, as I have said, to the insulin resistance test, because almost all the authors have used surrogate marker, but not the gold standard test. So can we really identify the patients that are more likely to be insulin resistant? We can use the PCOS phenotype, or we can identify our patient according to the BMI or according, and the most logical, the proved insulin resistance. So you have seen in the previous lecture that PCOS is a syndrome, and the syndrome is an association of different signs. And according to this different association, we may have different phenotypes. The oldest one is the NEH phenotype. In here, the patient should have the both signs, the anovulation and the hyperandrogenism. This is the most severe phenotype, regardless of having or not PCOS aspect on ultrasound. But the newly added phenotype by Rotterdam are the hyperandrogenism without anovulation and the anovulation without hyperandrogenism. And as you see, the distribution is almost the same according to the different study. The NEH phenotype is the most frequent one. But the insulin resistance differ according to the phenotype. The patients that have both hyperandrogenism and anovulation are more likely to be insulin resistant. And in these two studies, the authors have found that the patients that have hyperandrogenism without anovulation are more likely to be insulin resistant. But this has been contradicted by other studies. So what we know that the patients that have the severe phenotype, both anovulation and hyperandrogenism, are more likely to be insulin resistant. Can we identify the insulin resistant according to BMI? For sure, yes, because the obese patients are more likely to be insulin resistant, as it is shown in this meta-analysis. And in all studies, the obese patients are more insulin resistant than the lean or the overweight patient. So we know who are the insulin resistant among our patients, but this doesn't necessarily mean that this patient will really benefit from an insulin sensitizers treatment. So to help to answer to the second questions, we have the last meta-analysis by Tang published in 2012. And before I show you the results, I have to remind you that we may use the metformin treatment, for example, alone as a first-line treatment for ovulation, combined with clomiphene before or during IVF or during pregnancy. In this chart, I summarize the main results from the Cochrane database analysis. So as you see here, when we compare metformin to placebo, the metformin is superior. It induces ovulation, and this is significant. And this is also significant for the clinical pregnancy rate, but in all the population of PCOS, but especially in patients that are not obese. And it was not significant for the live birth rate, which was very disappointing. And when we compare the metformin to clomiphene, clomiphene is superior for the ovulation and for clinical pregnancy rate and for live birth rate. And metformin have been effective in patients that were not obese. And finally, when we compare the clomiphene alone to the combination of the two treatments, the clomiphene and the metformin, the combination was more effective in inducing ovulation and to obtain more pregnancy, especially in patients that were obese. And the live birth rate was not significantly different. We can conclude that, according to this meta-analysis, the metformin was effective in non-obese patients, and when we compare it to clomiphene, clomiphene was better and more effective, especially in obese patients. And if we face clomiphene resistance, or when we are dealing with obese patients, we may add metformin to clomiphene. This has some clinical implication because metformin seems to be not effective in all PCOS patients, and clomiphene is more effective for inducing ovulation and pregnancy. So we do not have to use metformin alone in obese patients in order to obtain a pregnancy. And adding metformin to clomiphene seems to be effective in patients that have some clomiphene resistance. And this maybe is underlying a little effect of metformin in case of severe insulin resistance. Can we select the patient that will respond to the metformin treatment according to their phenotype? I didn't find so much studies that focused on the subject. But in this study, as you see, the two groups that were sensitive to the metformin treatment, and in this group, they improved really their pregnancy rate. These two groups were the NEH group without the PCO aspect on the ultrasound and the hyperandrogenic patient without an ovulation. And surprisingly, these two groups in this study were those who were the less insulin resistant. That means that the metformin was effective in the less severe insulin resistant patient. Can we select our patient according to insulin resistance attested by several tests? In this study, the metformin had been significantly effective only in hyperinsulinemic but lean patient, non-obese patient. So the reproductive outcome are improved not in all patients, but in non-obese more than obese patients, and the patients that are resistant to clomiphene treatment may benefit from the metformin treatment. And we have not enough data to administrate the metformin treatment according to phenotype or according to insulin resistance. The other insulin sensitizers haven't been really studied for the reproductive outcome. And here, as you see, the rosiglitazone have been significantly effective for the regularity of the menstrual cycle, but not for inducing ovulation. So what we can conclude, the metformin is not that magical potion that will work in everybody, the obese, non-obese, and all PCOS patients. The benefit is small in all patients, take it together. So we need a more targeted population. And we have to ask ourselves, what is our goal with our patient? We cannot really compare clomiphene to metformin because those are two different drugs. Clomiphene is made for ovulation treatment. It has direct and quick action, and metformin have a metabolic action. So they are really different, and it is a long-acting treatment. And as you see in this slide, the metformin starts to be effective after 5 and to be superior to clomiphene after 5 cycles of treatment. So sometimes good things take time. So if we ask ourselves and our patient, what is our goal? If you are looking for a quick pregnancy, you have to use clomiphene or other therapeutics. But if you are looking for ovulatory cycle, and why not a pregnancy, by the way, you can use metformin alone, especially in non-obese patients. And if you are facing clomiphene resistance, you may add metformin. And of course, according to the consensus of Thessaloniki, if you are facing a glucose intolerance, you can use the metformin. You have to use metformin. Let's move to the metformin during the pregnancy. These new published meta-analyses have showed that we may observe less pregnancy loss when we use the metformin during pregnancy, but also less gestational diabetes. This review also agree and have stated that we may observe less early pregnancy loss. During IVF, it has been shown in the previous lecture, the meta-analysis by Palamba have also confirmed that we have less ovarian hyperstimulation syndrome, but also an improved implantation, less miscarriage, and this is probably due to a lower estradiol and less oocytes. So this slide is to remember us that our patients that are looking for pregnancy may have also some metabolic disorder. So we have to, maybe we can also prescribe and administrate the metformin for metabolic purpose. The Cochrane meta-analysis by Tang have also studied the metabolic outcome when we use insulin sensitizers. And it was very disappointing because the metformin have been effective in reducing a little bit the level of testosterone and the level of insulin. But the rosiglitazone have had a minimal effect and also increased the BMI, which is the opposite of what we are looking for. And pioglitazone have no effect. But this meta-analysis had as a primary endpoint the reproductive outcome, and this was only the secondary endpoint. So you have to take this with caution. So some other publications have arrived after this meta-analysis, and they confirm that the insulin sensitizers cannot change radically the metabolic outcome in PCOS patients. And we have few data about the long-term risk and the benefit of administrating metformin for preventing the cardiovascular disease. We have also to be aware that the metformin is not inoffensive. Many of our patients will experience side effects like gastrointestinal side effect. So we cannot give it and say it may work, it may not work. So as a conclusion, should all PCOS patients take insulin sensitizer drug? Of course, no. For the reproductive outcome, it have a limited action and a long-term action. So in women without urgent pregnancy desire, and especially non-obese patients, we may prescribe metformin. For the patients that are resistant to clomiphene in combined therapy, during IVF, it seems to be beneficial. We need more consensus as well as during pregnancy. The effect on hirsutism is small and is less than what we can expect with the treatment with the OCP. And for the metabolic outcome, of course, we have to administrate metformin in case of impaired glucose tolerance, as it has stated by the consensus of Thessaloniki. Thank you.
Thank you, Dr. Khrouf, for this excellent presentation. And perhaps a question. Yes? Yes?
Thank you, Mohamed, for this nice presentation. We usually talk about lifestyle. Style is very important. What does it mean? Is it possible to lose weight easy? Your experience about this? Is it the work of gynecologist, endocrinologist, psychologist, or surgery? My second question, what do you do when we have to treat hyperandrogeny and infertility?
So for the first question, in my experience, and all of us know that it is very hard to obtain weight loss in a PCOS patient. And in my opinion, we need a more multidisciplinary action for our patient. I think the gynecologist cannot do it by himself in all cases. And there are some cases he needs the endocrinologist, of course. And for the second question, it was about?
Hyperandrogeny and infertility.
In this patient, of course, we cannot administrate the OCP, so giving metformin is a good option.
Merci Mohamed. Je vais vous poser la question en français. Si jamais on a utilisé la metformine parce que le citrate de clomiphène a échoué, et lorsque la femme fait une grossesse, si on décide de continuer le traitement par metformine, ma question, quelle est la dose à utiliser et est-ce qu'on utilise pendant le premier trimestre seulement ou pendant toute la grossesse pour essayer de bénéficier des effets bénéfiques de ce traitement pendant la grossesse?
So the question was if we are using a combination of metformin and clomiphene in order to obtain ovulation in the pregnancy, what is the dose and what we have to do if we have to continue the treatment to the term or to the first trimester. So the answer is that the dose, here it depends. What we, the dose that have been reported by the different authors are from 1,000 milligram to 2,000 milligram. It's the dose that you need to obtain an ovulation. And the second, the meta-analysis seems to say that we have to continue the metformin to the term, but this is not a confirmed data. You have to confirm that. But in this meta-analysis, it showed that we have less risk of type 2 diabetes and pregnancy loss. But we have to take this data with caution.
Just a little comment for lifestyle. To lose weight, we don't tell patient to lose weight. She must be referred to the nutritionist. It's the business of the nutritionist. And when the weight is lost for 5%, and if there is no other infertility factor, the pregnancy will happen.
Thank you for the comment. Thank you. Yes? Yes?
Congratulations, Mohamed. My question goes for all speakers. In case of women coming for infertility, seeking a baby, do we have to take in charge this woman with a team, endocrinologist, gynecologist, cardiologist, or just as a gynecologist and we don't have enough training in endocrinology and so on?
I will maybe answer. I have to confide you a secret. For example, when we were entering to the room, I was discussing with Dr. Ben Slema about maybe a collaboration between us, and maybe one of the team of Dr. Ben Slema will come to help us with our PCOS patient. So definitely we are believing that we have to be a different specialty to help this patient to have their pregnancy and to avoid the metabolic disease.
How do you work in Netherlands or in Greece?
Sorry, we have to
move on because we have the last presentation.
Thank you, Mohamed.